Welcome, everybody. This is Matt Seefeld with Metrics. I'm excited to present here with Andrea at Pacific Rim Orthopedic Group and talk to you a little bit about streamlining revenue cycle management by really using analytics, tools, and techniques. A little background on myself. I've been with Metrics for a few years now. I've spent my entire career in healthcare revenue cycle consulting and technology development deployment. My focus has always been on process redesign, making sure people and process are aligned with technology to really improve the financial position of organizations. Andrea.
Hi, thanks, Matt. So I'm Andrea, and I'm the clinic administrator here at Pacific Rim Orthopedic Surgeons. We are a small private practice in Bellingham, Washington, which is just about an hour and a half north of Seattle. I have my master's in business, and I'm also Six Sigma Yellow Belt certified, and so that has helped me with some of the things that we have done here in the practice. So the thing that I'm going to talk to you about today is essentially a case study of our life before and after analytics and outsourcing. So the Pacific Rim Orthopedic Surgeons was originally founded in 1968. We currently have 4 physicians and a couple physician assistants, and hopefully growing. We see between 15 to 16,000 patient visits per year, and the big hospital group that I used to work for is actually now our biggest competitor, and their orthopedic group is about twice the size of ours, and we pretty much share a driveway with them. So we have to provide a really good value proposition for why patients should choose us over them. So when I joined the group, there were a lot of culture changes and high staff turnover. Just like every administrator, I had a really hard time hiring quality billing department staff. My billing department staff were either limited or really sporadic. So for example, when I first got here, the surgery biller was a per diem billing department person who had about 3 different jobs. So her time with us was really sporadic. I never had the ability to look into her charge submissions and see where she was at, how far she was behind, or if she was. And then part of that was the data analytics and resources were really cumbersome. So we didn't really have any automation of our revenue cycle management. And we spent a lot of our time managing data in dozens of spreadsheets. So I couldn't see how things were changing or were happening over time, which of course resulted in the really poor visibility of key performance indicators and how our overall financial performance was from one month to the next, from one year to the next. As I said, we were living in a world of spreadsheets managed by 4 different people. And so we were just overwhelmed with all this manual data entry. And anytime I needed a report, it was manipulating about 4 to 6 different pivot tables. And again, I couldn't see anything from one month to the next. I couldn't see any trends. Keeping up was just a constant daily struggle. And the joke that I make is that as long as no one ever called in sick or took a vacation, we were fine. And as any administrator knows, that's a laughable statement. So we were just having a hard time keeping up, and I never felt like we could get ahead. I constantly felt like we were having to put out fires all the time. That created a real major lack of insight into the practice's financial performance in all the key areas, including physician productivity, collection rates, days in AR, refunds due, and every decision was based on the physician's feelings about things instead of being based on data. And just as an example, one of the billers at one point in time told me that she only reviewed the credit report once a month, and she never cut more than about 5 refund checks in a month because it made one of the physicians feel suspicious. And I'll let you know how that ended up turning out in the end, because that did not end well. So my desire for a better way. I knew that there was a way to automate a lot of this stuff, and I knew that there was a better way to manage revenue cycle management in a proactive way. I'm also the kind of manager that I want to empower my staff. A couple of my folks were really, really smart individuals who have had tons of experience, and I wanted to actually utilize their energy and their talents to have them focus on resolving more complex issues instead of just doing data entry. I also wanted to be able to access those key performance indicators so that I could make better decisions and have those insights to help create some efficiencies and optimize the practice's financials and operations. And again, as administrators, the thing that we're constantly hearing is, how do we reduce overhead? How do we reduce overhead? Well, if you don't have data that you can keep track of over time, you can't see where efficiencies are, and you can't see where things are broken. And so I knew that it was possible to have that. And then so I really wanted to figure out a way that we could get to that point where we weren't just stuck in manual data entry. But of course, once you have folks who are doing what they do and they've been doing it for a long time, there is a fear of change. And the other part about this too is that I knew MedEvolve, who was our practice management system at the time, I knew MedEvolve offered these kinds of services. But of course, the docs also had an attachment to that, to keeping everything in-house too. And then on top of that, the cost versus the benefit, the cost of outsourcing versus the downstream benefits of that was just simply unknown at that point. Staff felt that extreme ownership and were reluctant to relinquish control over their tasks or clue me in as to what they were doing on a day-to-day basis. And then any significant workflow change, it would require major staff buy-in and also partner buy-in. So you may be asking, well, how did we make the change? One thing that, again, is administrators, and we're even seeing this now, there is always an opportunity when a crisis arises to make some changes. And I have been saying this before COVID-19, never let a good crisis go to waste. So this is, I'm going to give you a little bit of a lowdown of what happened in our practice. So I started with this group at the end of 2015. Our per diem surgery biller gave her notice in 2016. And then we had a different billing employee diagnosed with stage 4 cancer. She continued to work part-time with us while undergoing treatment, and that was in 2017. By the way, she is still with us. And then just a short while later, I discovered that a Keystone billing employee was essentially cooking the books and was embezzling money. And I discovered that in June of 2018. And by Keystone billing employee, she would essentially have been considered the lead or the supervisor of the billing department. So that's why I say that she was the Keystone billing employee, because she really held a lot of the knowledge of what happened in our billing department. And I had to fire her pretty much on very, very short notice. And then shortly after that, a physician partner abruptly gave his 30-day notice to leave the group in July. And then his designated PA and one of our surgery assistants provided her quote unquote retirement notice 2 weeks later. So I had some major crises happening, and so I had to figure out a way to manage it. And so that was essentially how I made the switch. And so as soon as all this stuff happened, the partners essentially were in enough pain and they were worried about their billing enough to the point where they said to me, essentially, we are over this roller coaster. We will do anything to make the bleeding stop. And so as soon as the partner left in July of 18, I essentially called up MedEvolve and I said, we need some help. And so MedEvolve started taking over a lot of our tasks in August of 2018. They took over the bulk of the billing and claims processes and the patient bill pay. And then as we were able to start resolving some of those long-standing issues, such as, backlog refunds, redundant claims, things that we didn't have capacity to do, we just slowly started to give MedEvolve more and more of the billing activities. And I said a few minutes ago about that one billing employee, this is the resolution of that issue, about the one where she said that she only looked at the credit report once a month and only cut about 5 checks per month because she didn't want anybody to look suspicious. Well, it turns out that as soon as we handed a lot of these day-to-day processes over to MedEvolve, we pulled up that credit report and it had tens of thousands of dollars of unresolved credits on it. And that took us several months to resolve. A lot of the things were posting errors. And so we were able to go through and make sure that postings were corrected. But a lot of them were past due credit refunds that we had to make sure that we got out the door ASAP. And I'm happy to say that that credit report is now fully in compliance and people get their refunds when they're owed. So that was the kinds of stuff that we ended up finding on the back end. So once MedEvolve started taking over a lot of that data entry, then we were able to start keeping track of things over time. So then the second part is that we were able to start getting some reports. And then the first one that we were able to get was the RCM Scorecard. And so essentially what this is a packet that we get at the end of the month as soon as month end closes. And it gives us an overview of the practice's high-level financial status. We go over it with a designated person each month so she can help us look at different things on it. From month to month, we'll go back and she'll say things like, hey, remember when we were working on that one thing last month? Well, let's take a look at that this month and see how that's changed. So we're able to look at up-to-date key performance indicators, including collection rates, days in AR, first pass resolution dates, collections, write-offs, all of those high-level key performance indicators that help you know what your practice is doing. It also gives us the ability to look at benchmarks and compare those to other groups in our geographical area or our specialty. And then also I can pull benchmarks from other places, say from MGMA benchmarks, and compare those to what is on my report to see how we're doing in comparison to those. The other thing I can do is that I can access these key metrics anytime. And so there we have access to a cloud-based analytics program. And so at any point in time during the month, I can also log on to this website and see any of this information in real time. So I'm going to give you some snapshots of our current scorecard. This gives me the ability to assess my revenue cycle on the first of each month and go through this and look at it and get into detail. But I can also do it in 5 minutes. You know, I can take a look at this first page and say, okay, how are we doing on charge leg? How are we doing on new patient visits? You know, I can kind of just get a high level overview. And then the next thing that it helps me do is I can take a look at something and say, okay, just looking at charge leg, for example, the amount of time it takes us to have a visit and then submit that visit for billing. Is there something that I can be doing to improve on that? So say, for example, the office, the first line there, charge leg office, the benchmark is 2 days, well, we are closer to a week. How could I improve on that? And then also it helps me look at any of the process changes that I have already put in place and see if we're making improvements over time. One of the sheets that I really like is the net collection rate sheet. I like to see where we are with a gross collection ratio there. I could like to take a look at my charges and payments over time to see if we're noticing any trends there. We know that we typically collect around 51%. Our gross collection rate is around 51% or so. Have we made any changes to our payer contracts that, maybe those are improving over time? I can take a look here. And then all the way there over to the right, the net collection rate, we typically collect about 98% of what we are owed within about 8, 9, 10 months. And I like to look at this and see, is that changing? Is it taking longer to collect? Is there anything that we can do to shorten that net collection rate? Another one of my favorite reports here is payer mix trending. And so I have this one table here that is payer mix by charges and then payer mix by payments. And so I can see for each payer how we are doing based on charges and payments. So for example, for charges, Humana just opened up a plan in our area recently, so I can see how that change in the payer mix is affecting, do we have a lot of patients coming in who have Humana or are not so many? And so I can keep an eye on that. And then one of the things that caught my attention a few months ago was that self-pay pass-through line, which is second to Medicare. That is the patient's responsibility after their insurance has paid. So as you can see, that is a pretty big chunk of our payer mix by payments. So I can look at this and say, have we made sure that every single one of those patients have a credit card on file? Do they have a payment plan? I can take a look at that self-pay pass-through group and make sure that we are going to collect that money timely, because that being the second line item behind Medicare and then before our other payers, that's a pretty good area of opportunity for us. And then here is another example of a payer mix report that actually has each payer over time. So we can take a look at this and see what our gross collection rate by payer is over time. And so this is just another way to slice and dice the data. And then appointment review is a really helpful report for me as well. How are we doing on cancellations, and how are we doing on no-shows? I can tell you the canceled by office for March is significantly higher because of coronavirus. We ended up having to cancel a whole lot of appointments. So I will be able to use this report to look back and say, see, here is how coronavirus significantly affected our business downstream. Another way that I've used this historically in the past, looking at that canceled by office, is that, unfortunately on our website, one of the things that we have to post is that we regret to inform you that we have to cancel appointments sometimes because the doctor has to go into urgent surgery and we need to pull a physician assistant from the office to go assist him. So I can look at the number of canceled by office and bring that to the physicians and say, we're canceling a lot of our appointments. Maybe it's time for us to hire an additional physician assistant. The other part in looking at this is the number of no-shows here. So over on the right, the number of no-show patients. And so I was able to use this report to show to my front office lead, hey, are you following up with patients who have had too many no-shows, and letting them know that we do have a policy. And so when we were seeing a high number of no-shows, we wanted to make sure that we were sending folks letters or notices or calling them on the phone to say, hey, you've no-showed or same day canceled your appointment 2 times, just to let you know we reserve the right to not see you again after that happens again. And then one part that is helpful for us to look at, if we're having blank spaces on our schedules, this report goes back and looks at what our estimates were for essentially what we would have gotten otherwise for that appointment, and helps us understand what the opportunity cost of having not had a patient in that spot. One thing I did want to mention on this no-show, this was something that was actually staff initiated, is that about once a week I'd have somebody from the clinical staff, somebody from the front office, and they'd come up to me and they'd say, gosh, it really seems like our Medicaid patients no-show a lot more than everybody else. And I'm always wary when somebody comes to me with it feels like, or it seems like, without data. And so I said, well, hey, let's pull the report. From this report, I was able to drill down these numbers. And sure enough, on the report, it showed that our Medicare population no-showed 2 or 3 times as much as patients who are insured by other payers. And then interestingly, the other group that also no-showed about as much was the Medicare group. So that helped us put some actual data to some feelings. And then we were able to communicate better with these patients to say, hey, just so you know, we do have a no-show policy. So then it helped us with our upfront communication with patients as well. Okay, so another way that the revenue cycle management scorecard has really helped me find issues up front and catch them before they become, burning fires. We had an issue about this last summer in regards to some unprocessable claims. And over here on the left, the self-relationship to holder validation, there was a claim edit change. And so we were still doing things the same way. We were entering people's information the same way, but there was a claim edit change. And so we didn't know about the claim edit change. And so we were looking at this report from one month, and we typically have, self-relationship to holder. In our case, it was a middle initial thing where we enter the middle initial into the practice management system, but the middle initial isn't always included on the patient's insurance. So that was causing those claims to kick back, whether or not the middle initial was there or not. And we typically have about 23 of those issues in regards to that specific error. Well, over the course of a couple of months, I noticed that number started to go up. So here it's 50. Here we have 101 unprocessable visits. This month it went down to 87, and the following month it went up to 136. So I called up my MedEvolve person and said, hey, I need to talk to somebody to see what's going on here. And sure enough, that's when we discovered it was a middle initial issue. And so then we corrected that. And so then the following month, that same issue went down to our usual 20 unprocessable issues. So it's just an example of how we were able to use a scorecard to catch things up front. Okay, so let's talk a little bit about accounts receivable. The scorecard has several different reports looking at accounts receivables. And it just depends on how you want to slice and dice it. You can do it by payer, you can do it over time, and you can drill down to each one of these things. And I like to look at this and see how we are doing based on benchmarks. I like to look at the MGMA benchmarks. I like to call up my other orthopedic colleagues and see how they're doing, or if they're noticing any trends. And making sure that anything over, 6 months old, everybody's got payment. I want to be able to drill down to everybody over the 180 days mark. I want to get to the patient level and make sure those folks have a credit card on file, they have a payment plan, and that we're collecting that money as much as possible and that we can. And the great thing about this, particularly right now, is due to coronavirus and COVID-19, we had to cancel a bunch of our surgeries and our appointments. Well, now one thing that I can ask MedEvolve to do is I can say, hey, let's really look at our AR and see if we can collect some of those payer balances to help continue with our cash flow. So that I can use this report and drill down, even to the physician level and say, hey, Dr. So-and-so's surgery AR is a little out of control in the 181 to 365 day. Let's drill down to his AR and see if we can collect some more on that. And so I can ask the MedEvolve team to focus on that, even though, we've had a significant reduction in the number of surgeries and visits that we're seeing now. So that's one way that I can really utilize this in real time. The other thing that I like is that I have a provider view, and I share this particular page with each one of my physicians each time we do our financials meeting. And the providers have complete visibility and transparency into their revenue cycles, and there's different dashboard options for them based on how they understand stuff better. So at the top here, I have the charges and the payments versus the last year. So the teal number there is current year, and then the red line is the previous year. So I can see any changes by year. Again, I'm going to suspect that March and April and probably even May compared to last year, I can then again utilize this report to show this is how, say, coronavirus has really affected us based on, and is different than it was last year. The other graphs that I really like on this page are the E&M bell curve graphs. So I can compare the teal line there is their actual coding. And then the red line there is the benchmark. And so I can show them how they can improve on their coding based on benchmarks. And then this report too has number of visits, number of new patient visits, charges and payments over time. So this is information that they are often asking me so that they can see the changes in their volumes as well. And then this is just another snapshot of a different page that I have. And so I can also show them these numbers 12 to 13 months at a time so that they can see the difference from this time last year. Okay, results after outsourcing and analytics. So I can say that after probably took about 6 months for us to get really efficient, and for about a year for us to be able to make some real significant changes in the practice. We were able to improve staff productivity and streamline our operations. We eliminated the need for 2 billing employees, and so that was the reduction of about 1.5 FTEs. For us, it happened essentially through attrition, either people quitting or, me firing the person who was embezzling. So the great thing about it is that I didn't have to then rehire those people or spend my time trying to find new people. And so that helped me be off of the staffing roller coaster. We really transformed the practice by highlighting areas of success and then flagging areas that needed improvement. And again, work with MedEvolve to improve our processes or their processes. I really like to ask them, what best practices are, what do other practices do and that have these kinds of situations. And then the big part for me and for my physician partners is that we are truly making decisions based on data and not on feeling. And that is a really big thing for us. It helps take the emotion out of the conversation on both sides. And then inevitably, when it comes to the bottom of it, we can drill down and understand those positive and negative trends and then make the necessary changes for improvement. And that's the bottom line of what our goal is. For me, one thing that's really important is that my people feel engaged and motivated and appreciated. And this was one thing that I really wanted us to be I wanted my staff to have for themselves, because we were able to automate these processes for a more effective revenue cycle management. My staff felt empowered and like they were able to make decisions and spend their time thinking critically, because I just don't have time to think critically for everybody. I need people to be able to work as hard as I am working. And so now I feel like my billing, especially my billing staff, more often come to me with, hey, I was noticing this on our scorecard and I have some ideas for how we can improve this process. And so I am just tickled whenever I hear that statement, because I'm like, yes, tell me what you think. You guys are the ones doing the work. So that made me feel really happy, is that I feel like my staff are happier in what they're doing. Okay, the impact of data. This is something that's really helpful for me because physicians are humans too, and they do have feelings, but unfortunately, feelings are not always factual. And so I'm going to give you a couple of real life examples of actual conversations that I've had with a couple of my providers based on this data and having these reports. So one that I commonly get is doctor comes to me and says, it feels like I'm seeing fewer new patients than, Dr. So-and-so. And so I'm like, hey, let's pull the report and see what it says. And so them on the left here are the other Dr. So-and-so. So these are 3 different doctors. And you is doctor on the right who thinks that other people are seeing more patients than him. So them, if you look down here at the new patient visit line, so them doctors are seeing 32, 38, okay, 73, 91, 60s, 50s. So they're seeing, on average about maybe 70, 80 new patients per month. You, on the other hand, doctor who thinks that everybody else is seeing more new patients than so you had 72, you had 58, 110, 136, 112, 82. So you are actually seeing on average about 100 new patients per month. So this helped me have this conversation. And essentially, as soon as I showed this data to him, it was the end of that conversation. Okay, so the next one I had was from a physician assistant, actually. So I noticed his charge leg was creeping up. So on this graph here below, the teal line is the service to charge entry lag. So that is the time it takes from when the provider sees the patient to when they actually submit the charges. And then the bar on the left is one of the physicians, and then the bar on the right there is the physician assistant. And so the lateral or the horizontal gray lines there in the background, those are the days. And so the first line there is 10 days, 20 days, 30 days. And so you can see the physician assistant is the charge leg is at somewhere around 12, 13 days. And we like the charges to get in within about 5 days. So I noticed his charge leg was creeping up. I had a conversation with him and I'm like, hey, it looks like I showed him the graph and I said, it looks like your service charge entry leg is creeping up a bit. Looks like you weren't getting your clinic visits submitted until, almost like 2 weeks later. And he swears that he submits his charges, quote unquote, same day. It must be because Dr. G, who is the MD, the bar graph there on the left, it must be because Dr. G is not submitting his surgery assistant charges timely because this PA assists that doctor in surgery. And I'm like, okay, well, that's interesting. I'll check in with Dr. G, but, just as a reminder, make sure that our policy says, that you have to get your charges submitted within 5 days. So then after my conversation with the physician assistant, again, the bar there on the left is the MD, who's the same MD. And then the second or the bar graph there on the right is the PA. You'll notice that the PA's service to charge entry leg decreased by at least half. I mean, his charge leg there is maybe somewhere around 5 days. It could even be like 2/3 that his reduction in days has gone down by like about 2/3. The physician, on the other hand, same doctor, his charge leg has actually gotten worse. So we know it had absolutely nothing to do with when the doctor was getting his charges submitted. But the point is that I got the behavior change. So that's the important part. Okay, so same doctor is in the previous example, and he just cannot figure out why he's not making as much money as he used to, should to, could to, needs to, all of that. So this is a snippet of actually 6 different months that I took a snip of so that you could kind of see a trend over time. And as you can see, again, at the bar, the teal portion of each bar is the service to charge entry leg. And you can see on average, his charge entry leg is upwards of 14, 15 days and has actually gotten worse over time. So the second to last one you can see is pretty much at 20 days. Well, the thing to note here is that the average of between 0 and 30 days of the month is 15. So what this physician is notorious for doing, and we all know that he does it, he knows that he does it, is that he sees all of these office visits and he won't submit the charges until like 2, 3, sometimes 4 weeks after he's seen the patient. So he'll get all the notes in there, but he won't submit the charges. Or he'll like get the notes good enough, and then, you know, he just wants to look things over and then he won't submit them. Well, at this point in time, this was, again, speaking in real terms here with coronavirus and us not being able to see as many patients, is that by reducing this charge leg, that could really help with cash flow right now. And so this was one thing that I spoke to him about. You know, over time, I keep telling him, you know, again, the policy is that they get the charges in within 5 to 7 days, 5 business days. And in this point in time, especially for March, April, May of 2020, this could really, really help us with cash flow, is because a lot of these payers are actually paying really, really quickly. And so if you can get that charge leg, Dr. So-and-so, down to like 3 or 4 days, that could really help you. So this is just an example of how this even applies now in coronavirus 2020 terms. Okay, and then just one last example. Again, same doctor, just can't figure out why he's not making as much money as he used to. So again, I'm like, well, let's look at the data and see if there's something you could be doing differently. This is, again, a snippet of 6 different months of that E&M bell curve for both new patient and established patient codes. And this is a 6-month overview for the same doctor. And you can see that the established patient code graphs, again, the teal line is his actual coding, and then the red line is the benchmark. For his established patients, he's billing pretty closely to what the benchmark should be. But you can see that for his new patient codes, his new patient visits, he is under coding. He could be billing more level 4s and maybe even a couple of level 5s. And the thing is about this doctor is specifically for him, I know he has the documentation and I know he spends the time, because he is notorious for running about an hour and a half behind in clinic, because he does not leave a patient until they are done asking their questions. His notes for his clinic visits are also many, many pages long. They are like dissertations for each and every patient. So I also know that he has the documentation there to justify coding higher for his new patients. So the thing is he's already doing the work. He just needs to code for it. And again, this could really help him right now with his cash flow, and this could help him get money in the door that he is desperately needing and that the practice is desperately needing. So this applies even now under this current crisis. Okay, so I am going to let Matt take over and go into a Metabol side of the presentation.
You know, I look at if you take COVID and you put it aside, you know, we still have challenges, right? You've got your insurance companies that are paying us less now than they ever have, right? They're more delay tactics, more first pass denials for things that are easily overturned. So you question why they denied in the first place. Yeah, and then you look at things like patient debt, right? The large amount of self-pay that's sitting out there on balance sheets now, and account receivable is a challenge. But I think the other thing when we look at revenue cycle is the amount of redundancy and tasks that we have been doing for, in our case, years that didn't need to be done, or they could have been streamlined very easily, right? Making sure that our clients' money is processing correctly, making sure that we're taking risk mitigation very seriously when it comes to staff turnover, right? You know, for us, we were really overstaffed. We weren't overstaffed based on the archaic tools we were using 2 years ago, but by inventing these new tools that have really streamlined our way we deliver services around revenue cycle, we've been able to reduce a lot of headcount, but we made sure that we could retain the best of the best, right? And we also have to make sure we incentivize the best of the best, right? Through bonus structures and things like that. At the end of the day, whether it's us as a rev cycle company or a practice management vendor, or it's you all running complex practices today, margin with no margin is no mission, right? If you don't have cash flow, you have no mission to do the things that you want to do in the community for the practice, in terms of growth, you know, and I hate it when I have independent physician groups saying, you know, I just don't know if I can do this much longer. I'm going to have to get employed by the hospital. But in reality, you know, I really, really want to stay independent. It's like, well, stay independent. Let's look at your cost to collect, and let's put some strategies in place, and let's put some technology in place that gets your margin back so you don't have to make those decisions. We talk about revenue clarity a lot here at MedEvolve. It's not a luxury anymore. It used to be, right? 10 years ago, 20 years ago, it was what it is. You still got good reimbursements coming through from insurance, but now it really is, right? It is an imperative to have, right? The technologies are out there. Big data has been around for, well, decades, but in healthcare, it's been a popular phrase on billboards at the big trade shows for over 10 years. Actually, coming up on 15 years now. AI is a buzzword now. We do employ AI into our workflow automation suite, mainly because it helps us make sure our folks are working efficiently, right? It helps our clients that do use our AI workflow suite. They want to make sure their folks are working effectively. Making sure that you can leverage data to streamline operations, right? If you've got to make decisions with your organizations, you have to have data to back it up. I mean, I loved Andrea's examples there with some of her providers. It's that they thought they knew what was going on, but once she uncovered the reality of it, behaviors did change. And that's important here, right? You all, if you're an executive and administrator of a practice out there, you don't have the time to ask for information and start analyzing report after report after report. It needs to be brought to you as a story, right? Something you can digest quickly, like I always say, over a cup of coffee, and know when you have to ask questions and take action. I want you all to spend your time designing action plans, getting results, not trying to mine data and information. That is, what sadly in this day and age, it's usually the inverse. People spend most of the month trying to mine information, leaving almost no time to enact change. When I think about standing out from the crowd nowadays, we're looking at PM systems to me, and we do half our business is practice management. We interface with hundreds of EMRs, every single day to deliver a revenue cycle for our clients. But look, it's a data warehouse, right? The functions are occurring in the PM, but it's capturing data. It's what you do with the data, though, that really does separate leading practices from the rest. I really do believe that. But you have to have tools that can grab that data, normalize it, and get it in the digestible format to you, in near real time. I think that when you look at KPIs, key performance indicators, when you're looking at things like that, it is important to really understand the industry benchmarks. I think it's also important to look at the KPIs that tell a story together. It's not just looking at a charge report. It's not just looking at a payment report. It's not just looking at AR. Like, you've got to be able to triangulate KPIs together. Like in our scorecard, we read it as a story left to right. And the intent there is for people to make informed decisions based on a lot of different data coming from a lot of different angles, right? So if your AR is going up on the self-pay side, right, then we should start to be able to see your net collection ratio going down because you've got higher self-pay balances going up. And if you start to see more patients being scheduled where they have prior bills not being collected, you would start to make the assumption that would be going up. And then you also probably start seeing bad debt write-offs because you're not collecting a lot of aged self-pay debt. So it's a long way of saying, look, you got to be able to look at a lot of different angles. But again, you can't look at this one at a time. You got to put these variables together and tell your revenue cycle story. And the providers really, in my experience, really love this, because then they start to be less emotional. They start to be more informed on their decisions and the impact to the business, and they can make constructive decisions.
The bullet that I would add down here is that as practice administrators, that we really need to focus on what our core competency is. And for medical practices, our core competency is medicine and seeing patients and treating patients. And the way that this relates to us right now, especially in this coronavirus crisis, is that because I've had this great partner with MedEvolve to work with on my billing and on, to do their core competency, which is revenue cycle management. When this whole crisis hit, I didn't even have to worry about that aspect of my business. The only aspect of my business that I had to worry about was what we specialize in, and that is how are we going to see and treat the patients who need to be seen and treated. So I could spend my time as a very busy executive type focusing on the things that I need to focus on, and I didn't even have to worry about the revenue cycle management, the billing. I knew that MedEvolve was handling that because that's what their job is. And so it took one worry off of my plate. And that, I think, really helps us stand out from the crowd, is that, while other practice managers are trying to figure out how they're going to get their billing in, now they've got to figure out how to get their billing people working from home, all that stuff. I didn't have to worry about any of that. That was completely something that I was like, well, at least I have that part handled. Now I'm just going to worry about how we're going to get patients seen. It brought me comfort to know that my billing was being handled. So I just wanted to add that on.
Yeah, no, I'm glad you brought that up. We were set up perfectly. We had every one of our staff members was home within 24 hours of our mandate. The CEO and I and the board met on a Sunday. We decided we were going to mobilize everyone at home that Monday, and by the end of that day, everyone was at home working virtually. And again, you have to have ways to measure production and outcome. You can't just send folks home and hope that things are happening, right? There's lots of distractions working from home nowadays, and I can attest with 2 small children. So it is really, really important there. And again, I think with Andrea, not to put words in your mouth, is I think because you have Scorecard, you have analytics, is that you have peace of mind that the work's being done the way it should be done. And when it's not, you can call us out, right? And I think that's also a really important aspect of outsourcing revenue cycle. You have to have the data and the analytics to know how well that vendor's doing, and the vendor has to have the same analytics to make sure that we know how well the clinic's doing.
Yeah.
So again, we appreciate the time. We know that we put out a lot of webinars. We try to produce good content for you all. We've tried to make sure that there's good thought leadership in there. If you have questions about this webinar or any of the webinars that we do, or any of the types of services or technology we offer, please reach out. Our contact information is here on this slide. So again, we really appreciate it. I want to thank Andrea very much for being a part of this webinar. We always enjoy when we can have a client on board. It just makes it a lot more personal for us. So I thank you again, Andrea, for joining us.
Thank you for having me.